Hello students, I am Dr. Priya, Associate Professor from the Department of Periodontology, Vinayaka Mission Sankaracharya Dental College. Today, I will be giving a presentation on the topic Clinical Features of Gingivitis. These are the contents of my topic. Today, I will be discussing what is gingivitis, the clinical features of gingivitis and what changes will be seen in the gingiva when it is inflamed. Now, let us go to the details. Gingiva is a part of the oral mucosa that covers the alveolar process of the jaw and surrounds the neck of the tooth. The inflammation of gingiva is termed as gingivitis. So, when the gingiva is inflamed, a lot of changes are seen microscopically as well as macroscopically. So, the changes are evident in the color, contour, consistency, position, bleeding and pain. So, in this picture you can see how the healthy gums appear and how it is appeared when it is inflamed. Now, moving on to the classification of gingivitis, based on the course and the duration, it is classified as acute gingivitis, chronic gingivitis and recurrent gingivitis. Acute gingivitis, it is given the term when it is of sudden onset, short duration and is quite painful. Chronic gingivitis is the most commonest one, the long duration, slow onset and quite painless. The recurrent gingivitis, it is given to the term when the gingivitis reappears even after being eliminated by the treatment. And based on the description, it is classified as localized gingivitis, marginal gingivitis, generalized gingivitis, papillary gingivitis and diffuse gingivitis. It is termed as localized gingivitis when the inflammation is confined to a single area or a group of area. The term is given marginal gingivitis when only the marginal gingiva is alone involved. It is termed as generalized gingivitis when the entire mouth is affected by gingivitis. Papillary gingivitis is given when only the papilla is involved in the inflammation, and diffuse gingivitis when the inflammation is involving the entire marginal gingiva, interdental papilla as well as the attached gingiva. So, based on this description, it is further elaborated as localized marginal gingivitis when the inflammation is confined to one or more areas of the marginal gingiva, and localized papillary gingivitis when it is confined to one or more area of the interdental papilla. The term localized diffuse gingivitis when the inflammation extends from the gingival margin to the mucobuccal fold in a limited area. It is termed as generalized marginal gingivitis when involves the entire gingival margin of the entire tooth. Usually here the interdental papilla is also affected. Generalized diffuse gingivitis is a term given when the entire gingiva is affected, including all the marginal gingiva, interdental papilla as well as the attached gingiva. Here sometimes the mucogingival junction is also obliterated. Now, moving on to the clinical features. Every disease will elicit this sign. Similarly, the bleeding on probing is the first sign of gingivitis, not the inflammation, not the swelling or the redness. It is a bleeding on probing. So, why does it bleed when you probe that particular area? When you see microscopically, the blood vessels, they are dilated, engorged, and the epithelium lining the gingival sulcus, it becomes thin and micro-ulcerated. So, when we insert the probe into the gingival sulcus area, naturally because of the ulceration of the epithelium, it breaks and bleeding recurs. And after some time, what happens when the irritation is removed? Naturally, hemostasis occurs and the bleeding is stopped. Bleeding recurs only when the area is irritated again. The severity of the bleeding depends upon the intensity of the inflammation. Now, moving on to the causes of the gingival bleeding. It can be either local factors and systemic factors. Again, local factors, it can be due to because of acute or chronic factors. Systemic factors, it can be because of hematological diseases and because of excessive usage of certain drugs. Now, what are the local factors for the gingival bleeding? The gingival inflammation is because of the plaque and the calculus. So, the factors leading to the plaque retention, namely not properly cleaned partial dentures, overhanging restorations, caries tooth, crowded teeth, malpositioned tooth, orthodontic tooth movement, frenal pole and certain anatomical and developmental tooth variations, these all have a tendency to accumulate the plaque and thereby leading to the gingival inflammation and affecting the gingival bleeding. Apart from this, acute gingival bleeding might be caused because of vigorous tooth brushing. So, when we do vigorous tooth brushing, the tooth bristles might affect the gingiva and cause injury resulting in the bleeding. Impaction of sharp pieces of hard food like impingement of the chips or biting an apple or bone pieces, they tend to injure the gingiva and cause gingival bleeding. Gingival burns from hot foods or chemicals, and the case of acute necrotizing ulcerative gingivitis, where there's even a slight provocation causes gingival bleeding. The chronic and recurrent bleeding. Chronic inflammation is because of the plaque and calculus, it causes bleeding. The bleeding is chronic or recurrent and is even provoked by the mechanical trauma like tooth brushing, toothpicks or foot impaction. We already saw the histopathology behind the gingival bleeding. It is because of the dilatation and engorgement of the capillaries and thinning or the ulceration of the sulcular epithelium. The sites that bleed on probing have a greater area of the inflamed connective tissue. The severity of the bleeding and the ease of its provocation depends upon the intensity of the inflammation. Those are the local causes for the gingival bleeding. Coming to systemic causes, certain hemorrhagic disorders also cause abnormal gingival bleeding like platelet disorders like thrombocytopenic purpura, hyperproteinemia, other coagulation defects like hemophilia, leukemia, Christmas disease, deficient platelet thromboplastic factor resulting from uremia, multiple myelomia, and vascular abnormalities like vitamin C deficiency, certain allergics like squalene hinoc purpura. Apart from that, the effect of certain hormone replacement therapy, oral contraceptives, pregnancy, menstrual cycle, changes in androgenic hormones, all these alter the gingival tissue response to the inflammation, thereby altering the gingival bleeding. Diabetes is a well-known endocrine disorder which will be well characterized by the gingival bleeding. There are certain medications which have an adverse effect on the gingiva, namely the anticonvulsants, calcium channel blockers and immunosuppressants. They cause long-term use, they cause gingival enlargement, thereby leading to gingival bleeding. Aspirin is a well-known drug which is used to treat the cardiovascular disease, have an adverse effect on the gingival bleeding. So, care should be taken while treating the patients who are taking aspirin. So, that is all about the causes for the gingival bleeding. Moving on to the color changes in the gingiva. As we all know, the normal color of the gingiva is coral pink. The color is basically because of the vascularity, epithelial thickness, degree of keratinization and melanin pigmentation. So, in the diseased conditions, the color of gingiva will be either pale pink, red or bluish hue on the reddened gingiva. The color of gingiva is red when the inflammation is increased, that is vascularity is increased and the degree of keratinization is decreased. The color of gingiva will be pale pink when the vascularity is reduced and the degree of keratinization is increased. The bluish hue on the reddened gingiva is because of the venous stasis on the gingiva, which is seen in the stage 3, that is the established lesion of the gingival inflammation. The color change usually starts in the interdental papilla and the gingival margin and then spread to the attached gingiva. So, these are the color changes in the inflamed gingiva. Sometimes heavy metals like bismuth, arsenic, mercury, lead and silver, when they absorb systemically from therapeutic use or occupational or household environments, they may also discolor the gingiva and other areas of the oral mucosa. This color is because of the perivascular precipitation of the metallic sulfates which get embedded in the subepithelial connective tissue. So, that appears as the gingival pigmentation on the outer surface. So, these metals usually they produce either a black or a bluish line in the gingiva that follows the contour of the gingiva. As you can see the pictures, the example bismuth pigmentation which shows a linear black color, amalgam which shows you have a violet line, and lead-induced pigmentation that is a Burtonian line that is called as causes a bluish black discoloration. Now, there are certain color changes which are associated with the systemic diseases. The endogenous oral pigmentation can be caused by either melanin, bilirubin or iron content. There are certain diseases which cause an increase in the melanin pigmentation, namely Addison's disease, Peutz-Jeghers syndrome, Albright syndrome. So, these diseases they produce some pigmentation in the oral mucosa, lips as well as the gingiva. So, that is all about the color changes. Moving on to the changes in the consistency of the gingiva. The normal gingiva consistency is usually firm and resilient. It is because of the cellular and fluid content and collagenous nature of the lamina propria. In inflammatory conditions, especially in the chronic gingivitis, it can be either soggy, edematous or firm and leathery consistency. Let us see what is the underlying microscopic features behind this consistency. When in the chronic gingivitis, when it is soggy puffiness that pits on pressure, the underlying microscopic feature is either infiltration by fluid and cells of the inflammatory exudate. When there is marked softness with friability, With pinpoint areas of redness and desquamation, the underlying microscopic feature is degeneration of the connective tissue and the epithelium. So here the epithelium is thin and the connective tissue is engorged with edema and leukocyte invasion. If the consistency is firm and leathery, the underlying microscopic feature will be fibrosis and epithelial proliferation. In acute forms of gingivitis, especially when you see in the condition like acute necrotizing ulcerative gingivitis, you can see a sloughing with greyish area. That is because of the necrosis with pseudomembranous, which is composed of the bacteria and polymorphonuclear leukocyte invasion. If it is diffuse puffiness and softening, we can see diffuse edema and fatty infiltration. So that is all about the consistency of the gingiva. Moving on to the changes in the surface structure of the gingiva. The normal surface of the gingiva, they exhibit numerous small depressions and elevations, giving the appearance of an orange peel. That is called as a stippling. This is an adaptive specialization because of the attachment of the gingival fibers to the bone. This stippling is a feature of the healthy gingiva. The stippling is restricted mainly to the attached gingiva and involvement of some amount of the interdental papilla. In gingivitis, there will be loss of gingival stippling. Moving on to the changes in the size of the gingiva. The normal size depends on the bulk, sum of the bulk of the cellular and intercellular elements and their vascular supply. In diseased conditions, the size is naturally increased. Example is like the case of gingival enlargement. Moving on to the changes in the position of the gingiva. Normally, gingiva is attached to the tooth at the cemento-enamel junction or 1 mm above the cemento-enamel junctions. So, in diseased conditions, the position will be altered. Either it can move coronally or shifted apically. Coronal proliferation of gingiva occurs in the case of the enlargement or pseudo pocket. And in the case where the marginal gingiva is shifted apically to the cemento-enamel junction, that condition is called as gingival recession. This gingival recession is defined as the exposure of the root surface by an apical shift in the position of the gingiva. So, this gingival recession can be either visible when it is seen clinically, and it is hidden, which is covered by the gingiva and can be measured only by the probe. In this diagram, you can see the exposure of the root surface. Now, you have to differentiate between what is a visible recession and a hidden recession, together called as the actual or the apparent position. Now, what is the actual position? The actual position is the level of the coronal end of the epithelial attachment on the tooth. Whereas the apparent position, it is the level of the crust of the gingival margin. So, here the severity of gingival recession is determined by the actual position and not the apparent position. So, this is about what is gingival recession. What is the reason behind the gingival recession? That so many reasons are there, mainly pathological, physiological, anatomical. The most commonest causes are the faulty toothbrushing technique, gingival inflammation, tooth malposition, aberrant frenal attachment, friction from soft tissues, orthodontic tooth movement in labral direction, and trauma from occlusion. So, based on the etiological factors, removal of the etiological factors, the treatment plan will be planned. Now, that is all about gingival recession. Now, moving on to the changes in the gingival contour. Normally, the marginal gingiva is scalloped and knife-edged, and the interdental papilla shape is pyramidal in the anteriors and it is cone-shaped in the posteriors. In disease conditions, this marginal gingiva loses its scalloping and become rounded, bulbous or rolled out, and the interdental papilla will become blunt and flat. So, changes basically are primarily associated with gingival enlargement, but some changes may occur also in other conditions. There are two different indentations in the gingival contour, namely Stillman's cleft and Meckel's festone. Stillman's cleft is used to describe a specific type of gingival recession consisting of a narrow triangular shaped gingival recession. You can diagram, you can see a triangular shaped gingival recession. As the recession proceeds apically, the cleft becomes more broader, exposing the cementum of the root surface. Then what is Meckel's festone? Meckel's festone usually described as a lifesaver shaped enlargement of the marginal gingiva. It is used to describe a rolled, thickened band of gingiva which is usually seen adjacent to the cuspid when the recession approaches the mucogingival junction. So, both this Meckel's festone and Stillman's cleft are peculiar gingival enlargements. So, to summarize, Today we saw what is gingivitis, the classification of gingivitis based on the course and the duration and the description, and what is gingival bleeding, the causes for gingival bleeding and the other changes associated with the gingival bleeding. So to conclude, we can say gingivitis is a common dental problem that is characterized by redness, swelling and bleeding on probing. It's a reversible condition. Once etiological factors are removed, the gingiva restores to its normal healthy condition. So prompt treatment can prevent the disease progression to periodontitis and ultimately prevent the tooth loss. Good oral hygiene practices, both the mechanical plaque control and the chemical plaque control, are crucial for prevention and the management of gingivitis. Hope you all understood my class. Thank you for watching my class. Have a great day.